at the Swiss Academy of Ophthalmology in Luzern. I have now the honor to talk to Dr. Gabriela Grimaldi from Lugano, and she has a very interesting topic, myopia. Dr. Grimaldi, myopia, there's the talk of a pandemic. How comes?
Yes, it used to be like the epidemic of Asia, but actually there's more and more myopic people everywhere in the world. And as a retina specialist, my interest is not just in myopia per se, all the refractive implications of the disease, but what complications can arise in myopic patients at the level of the retina.
Yeah. Who is at risk? Is it every myope or is it the high myopes? And how do you define high myope? Where does it start?
Now, the definition of high myope is actually about the refractive error. So more than 6 diopters, you would be like high myope. But a pathological myope, then that's a different story. So you can even have a like 5, 6 diopters defect, but that doesn't mean that you will get the complications. If you have like a minus 15, then it's pretty sure that you will get some complications down the line. And who's at risk? Like myopic macular neovascularization, it can get any myope, regardless of their refractive index. As for the most severe complications, the traction maculopathy, the risk of detachments, the very bad ones, the more myopic you are, the more at risk you are.
That almost answers my next question. The doctor who is not a retina specialist, what kind of symptoms, what kind of clinical images can he or she expect when examining a patient with myopic complications?
Yeah, right now it's very important to still do a thorough fundus examination, dilated to check the periphery very well, but OCT, so optical coherence tomography, has really changed the game here, especially for the myopic traction maculopathy and with the neovascularizations. With OCT angiography, you can really do well without the need of any dye and contrast agents.
How often do you recommend having OCT examination for these patients, like once a year?
Yes, once a year if there's no symptoms, but it's very important to tell your patient what to watch out for. So flashes, floaters, or metamorphopsia, blurred vision, then do not wait. Just get to your practice, do the OCT, and check what's happening.
Absolutely important. The kind of patients that you have, I mean, there are certain cliches about AMD patients or glaucoma patients. Whenever I had to deal with patients that had high myopia, I found them relatively alert and relatively cooperative. Is that your experience as well?
It is. They are younger than the classic AMD patient anyway, but they really know their symptoms. So you can really trust them when they're telling you that there's something wrong. Then it's worth checking what's happening because they know, they can feel it when something is changing.
And this is also a kind of demographic that is well educated. I mean, that's for 200 years ago, the first time it was showed that there's a connection between, you know, reading and studying on the one hand and becoming myopic on the other. Absolutely. And that is today even more the case.
Case in point, absolutely.
How do you treat these patients, particularly CNV?
Now, in this case, right now, with the revolution of anti-VEGF, when you see a myopic neovascularization, do not wait. Just put an anti-VEGF in. It doesn't matter which one. Is it ranibizumab, aflibercept? There's good evidence from the literature that both drugs work, and we'll probably hear more with the new generation drugs in the next few years. The good thing about myopia compared with AMD, you don't need a lot of injections. So you may get away with 1 or 2. So you just...
So not every 6 weeks or every 4 weeks over 10 years.
Exactly. Especially considering it's a younger population, you don't want to treat them every 6 weeks forever. You may very well just do well with 2 or 3 injections and then just monitoring.
That is certainly good news. And last question, retinal detachment, a well-known complication of myopia. How often do you see that? I mean, I guess the risk increases with the diopters.
It does. It's an issue after cataract surgery because myopic patients often want cataracts to be removed at an earlier stage because of the refraction implications. But then that we know can increase the risk of a retinal detachment. So once again, it's very important, the counseling. So you tell them that this can happen, the self-monitoring as soon as the flashes start to be seen quickly, and then do not wait. Like if there's a break with some fluid and a detachment, just treat it aggressively, because otherwise it's a very fragile tissue. It can go wrong really easily.
And I think this is a problem that will grow with the increasing numbers of myopes.
Absolutely, absolutely.
It's a field of ophthalmology that certainly has a future.
It is.
Great talking to you, Dr. Grimaldi.
It's been a pleasure. Thank you.
Thank you.